Okay. Well, welcome everyone to our Cure 18th of May 2024 meeting. Today we have three speakers, Dr. Wendy Chung from Boston Children's Hospital, Tom Stanton from Danny Did Foundation, and Crystal de la Grammaticus from Malan Syndrome Foundation. So we'll be starting off with Dr. Chung, and I'm going to let Dr. Chung do a brief introduction to herself. And we will be saving all of our question and answers until the last presenter. And if you do have any questions, you can post them on the chat or save them until after the last presentation. Thank you, Dr. Chung, for joining us today. I'm going to turn it over to you.
Great. Thanks, Caroline. And when I can, I'll share my slides. Caroline has been a great partner in a program that we call Simon Searchlight. For those of you who don't know me, I'm a medical geneticist. I was at Columbia for about 25 years, but recently became the chair of pediatrics at Boston Children's Hospital. And if I can share my slides, I will. If not, I can do this without. Oh, there we go. Okay, perfect. Okay, hopefully folks can see my screen. And there may be, I hope there are a lot of questions at the end, so I'll try and go relatively quickly through this. So as I said, Caroline's been a great partner in what we call Simon Searchlight. I'd started this actually 14 years ago to try and think about rare genetic conditions, neurogenetic conditions associated with a range of developmental manifestations, everything from epilepsy, autism, intellectual disabilities, ADHD, and the registry that we've set up, as you'll see, is trying to do this across many conditions. Yours is one of them. Yours happens to be one of the ones that always has struck me as being particularly urgent. And so as we've done this, we've tried to think very carefully about how to meet the needs of the research and the patient community as we've gone forward with this. So as I said, I didn't say, but this is an international online registry. We're increasingly, now that I'm at Children's, building in an in-person component as well as another anchor. And I hope over time we'll also have a way of being able to collect digital data from home. But right now it's mostly an online measure with a combination of filling things out on your computer as well as speaking with a genetic counselor. This is defined by gene, so everyone within this community is defined by gene, and as I'll show you, it's many different conditions. And just to give you a sense of the team powering all of this, it's a very large team. I won't go through everyone here, but a lot of alphabet soup and a lot of degrees and a lot of hard work and a lot of time zones to support everyone behind the scenes. And all of this, I should underscore, is free to everyone in the community. There's no charge for any group to participate, and all of the data are de-identified, secure, and then freely available to researchers around the world. So we do all of this to try and make it easier for you to be able to partner with researchers, as I'll show you in a second. Within doing this, we're also increasingly, specifically for epilepsy, actually have an online portal where individuals who are in the study can go from their dashboard and be able to see all of the data, again, de-identified, but presented for actually entered by anyone else in their community. And it's a really lovely way of being able to see when do seizures start over the lifespan, or how are people, what medications are people using for them? Are the seizures under control? What types of seizures are they? But information specifically about that, and as I said, to be able to self-serve, that is, to in your own community to see everything that we see relevant to seizures. As we're doing this, it's the goal of doing this, as I said, is to be able to help you and your doctors and your educators, your therapists, and then also researchers to be able to move things forward. And I hope that is what's being done. We have hundreds of researchers using the data, so I think it is starting. There's another component to this as well, or there are other components rather. Simon Searchlight, as I said, is based on having a genetic diagnosis, so that's labeled here. We realize that many people are undiagnosed and don't yet have a diagnosis, so I added on later something that we call SPARK, or Simon's Foundation Powering Autism Research for Knowledge. This helps some individuals get a diagnosis. Once they do get a genetic diagnosis, they can then come over and join the specific group here within Searchlight. And within this, as I'll be talking about, we also have resources being cell lines, in some cases animal models, and Safari at the Simons Foundation, uh, actually funding research from researchers to be able to put all these pieces together. Although it doesn't happen very often, we do have a process in place across North America to be able to collect brain tissue as well for researchers if there should be a postmortem case. Just showing you within this, these are many different conditions. Yours is one of them. And then within this, we have, it's not just a one and done, it's really baseline and then annual follow-up with many different standardized measures. We've chosen these specifically based on what groups like the FDA, the EMA are looking for in terms of outcome measures to give baseline data so that we've got a comparison should there be interventions, be they medications, ASOs, gene therapies, devices, software, whatever it might be. We've got baseline data for comparison, all of this online in many different languages, and also in many cases a small but a token gift in terms of participating with this. With this, we know that people may need to stop and start. Life gets busy, so we have all of the ability to do that. And we also have the ability to have genetic counselors that are literally around the world to be able to match your time zones, to think through if there are questions that you have, or if there are, in terms of doing the medical history, if it's complicated or there are issues, to be able to walk you through that. Once you do this, there's a dashboard that we have online to hopefully help you see where you are and where to go next in terms of going through that. With the registration, we do ask for a copy of your genetic test report so that we can verify that you're in the right club, and that you really do have the right type of genetic variants. 95% of the time people do, but I've personally taken people through when they thought they had the right diagnosis and it wasn't, and then finally gotten them to the right diagnosis. So that's important both for them and for the quality of the research data. This is what I was saying. It sort of the dashboard brings up and shows you what your next instrument is to be able to do. And then there's also, like I said, a small Amazon gift card token when you complete tasks. In going through this, where there are things that we're always listening to you in terms of understanding what the field needs, I'll point out the last item here, which is EEG, not just the records, but also the data. So we're starting to collect EEG data because we have heard from some researchers that the actual electrical squiggles are helpful in terms of trying to understand things. So we're trying to prioritize which groups and which researchers will find this most useful. We'd love to hear from you if you think your researchers would find this helpful, because we are setting up the infrastructure to be able to do that. As we're going through, I think it's important for you to learn together with us and with researchers. So we try and present this back, both individual reports. So there's many of the standardized instruments that the information may be helpful to you, your child's educator, their therapist. So we give you back a report, again, using that standardized scoring so that you can share that information. We also have what we call snapshots so that we can be able to, as a community, see what's going on, see where people are around the world, if you're thinking about where you want to have your meetings, things like that, and then also be able to present at conferences. So with this, I also wanted, and this is more for researchers, but all of the data are available through Safari Base. It's, as I said, a simple verification to make sure these are legitimate researchers. And again, the data are de-identified to go forward to be able to share that data. And then in some cases, we do collect blood samples to be useful for making induced pluripotential stem cells. This helps in terms of making brain cells in a dish, or models that can be used in the preclinical sense for testing new therapies, understanding disease mechanism. And so this is something that the Simons Foundation has underwritten for many conditions, and in fact, I think is being very widely utilized around the world. Within this, as I said, these samples do take a while, though, to set expectations, oftentimes 6 to 12 months before the iPSCs are verified to be ready to go. We do quality control to make sure that they are what we think they are. They haven't acquired any new properties. but in doing so, as I said, making those available to researchers around the world. These iPSCs, I know it sounds a little odd, but you can start with a blood cell and you can be able to make it sort of forget how it became a blood cell and be able to have it undifferentiated and then to make that into a very specialized cell like a brain cell. Then, as I said, this allows us to be able to model things in a dish without having to take a biopsy from someone's brain or to be able to test something that could be toxic. We can test that out in a dish before it goes into people. And so that's something that many researchers are using. Um, Within this, we also have another program called Research Match. This is a way for researchers to be able to contact participants and minimize over and over again, or to be able to go back and look at historical data. And with this, they can invite individuals, for instance, to clinical trials, to natural history studies, to being able, whatever there might be, if there's a new measure of sleep, to be able to look at that, a new measure of, or way of being able to look at EEG data or epilepsy. But this is not, again, Searchlight, but it's open up to the entire research community and just helps to make the whole process more efficient. So within that, let me pause. And there's going to be time at the end, I know, for questions, so I won't take any longer right now.
Thank you, Dr. Chung, for that. And yes, we'll save questions for the end. Our next presenter is Tom Stanton from Danny Did Foundation. Tom actually has a family commitment this morning, and so he'll be joining us a little bit later. So he had provided a video of his presentation. Now, Tom Stanton is the president of Danny Did Foundation. He's actually the uncle of Danny, the name of the boy that this foundation is named after. And they provide information and resources for seizure detection and prediction devices. So can you go ahead and play the Danny Did Foundation video?
Is there audio?
Olivia, can you replay and unmute the video?
Okay, playing unmuted.
Hello to everyone. My name is Tom Stanton, and I'm the Executive Director of the Danny Did Foundation. We appreciate the chance to share our story. The team at Danny Did believes that caregivers are the key drivers in changing and improving the standard of care for patients in the future. My colleague Mary Duffy and I will be presenting, and I'm going to start by sharing the story of my nephew, Danny Stanton, who you can see pictured here, and who is the inspiration behind the Danny Did Foundation. Then we will talk about Danny's cause of death, which was sudden unexpected death in epilepsy, or SUDEP. We are also going to highlight some resources that we believe can help to keep people who face epilepsy safer. So on this next slide, I want to start by introducing you to Danny. Danny was an athletic and affectionate child who enjoyed doing everything with his two older siblings, Mary Grace and Johnny, along with his younger brother, Tommy. Danny had his first seizure at age 2. His parents witnessed just 4 more seizures over the next 2 years. He was relatively well controlled by medication. Just a few months before his 5th birthday, Danny visited his neurologist on a Tuesday, where he received a slight modification to his medication due to his weight gain, and they were told they were on a good path. 4 days later, on a Saturday morning, Danny was found deceased in his bottom bunk bed on December 12, 2009. The first time his parents learned the term SUDEP was on Danny's death certificate. His parents, Mike and Marianne, started the Danny Did Foundation to fill gaps in education and communication that they experienced during the treatment of Danny. The name of our organization comes from the last line of his obituary, which was written by his dad, and which read, "Please go and enjoy your life. Danny did." Despite our tragic origins, it is the spirit and joy of Danny's life that motivates the Danny Did Foundation in our work to help other families. The next slide. There are many fantastic epilepsy organizations, and our goal is not to overlap with the work that they do. At Danny Did, we have two main points of focus. First, to increase public awareness about epilepsy and the risks that accompany it, and in particular, the risk of sudden unexpected death in epilepsy. We advocate for honest and open dialogue between doctors and parents. As all of you know well, caregivers can and do digest difficult information about risks all the time. At the end of the day, it is our job as caretakers of our kids to consume information and then to shape the best possible treatment plan. Our second area of focus at Danny Did is to increase awareness of and access to devices and technologies that alert to seizures. This next slide, we talk about the risks for people with epilepsy. And as everyone knows, there are several risks that accompany a diagnosis of epilepsy. Risks related to falls and injuries, swimming, bathing, driving, and head trauma are all important to be aware of. The sad reality is that there's also a risk of mortality with epilepsy. SUDEP is one of those mortality risks. According to the National Institutes of Health, SUDEP is the most common epilepsy-related cause of death. The exact causes behind a case of SUDEP are still being studied. So it is important to follow good seizure management practices, such as avoiding triggers and looking into all available therapies. A discussion with your doctor to determine where you or your loved one fall on the risk continuum is extremely important. The Danny Did Foundation stresses the importance of caregiver intervention during a seizure to help reduce risks. When a caregiver is alerted to a loved one who is experiencing a seizure, they can come to their aid and provide support, which may include a rescue medication. The use of seizure detection monitors is one tool that can help to keep your loved ones safer. Before Danny died, his parents had never heard the term SUDEP. It was never a risk that had been raised with them by Danny's neurologist. That lack of disclosure, unfortunately, is not uncommon, but it is something that Danny Did is trying to change. Right now, there is no known 100% prevention tactic for SUDEP. No medication, no surgery, no diet, no device. But we do believe there are steps we can promote to patients and families to minimize the risk. One of those steps is to consider the use of resources such as monitoring devices that detect certain seizures and can alert caretakers and enable early intervention. Now I'll turn it over to my colleague Mary to talk more about these types of devices.
Okay, for the next slide, this slide is to acknowledge that there are several ways a non-invasive device system can attempt to detect seizure activity. Many of the systems in place today focus on movement, but there are several technologies in the pipeline that attempt to expand beyond just movement. Researchers are also looking at these indicators listed here to develop reliable devices. And for our next slide, we see devices and technology as a complement to medication, surgery, and diet as part of a patient's treatment plan. In other words, we view devices as another tool in the caretaker's toolkit. A device doesn't replace a parent's instincts or their vigilance, but a monitoring and alerting system can serve as one piece to the puzzle, lending backup that you will be notified if a seizure takes place. Monitoring for seizure activity within a hospital is important. Those monitors are very valuable to the nurses, to the doctors, and as well to the patient. But when a patient leaves the hospital, we believe that monitoring is just as important in the home setting. This list on the slide highlights that we believe alerting devices are so important for caregivers. We feel strongly about the simple concept of early intervention. If you are present, you can take action. You have a chance. Two of these points to highlight, which we hear about all the time from caregivers, are reduced anxiety and increased independence for patients and increased peace of mind for the caregiver. We could never overstate the impact of these factors for families who face seizures. And moving to the next slide, it is important to emphasize that monitoring devices have value not just for patients and caregivers, but for providers as well. The management and treatment of epilepsy are mainly guided by tracking of how often seizures take place. For very valid reasons, patient self-reporting and recall is known to be incomplete. Arming doctors with accurate seizure tracking data regarding the frequency of seizures can lead to more effective evaluation and optimization of seizure medications. That point alone from this list of benefits should serve as a key motivator for providers to understand the value of monitoring devices. All of this being said, we don't pretend that the current available devices are perfect. So Tom will speak now more about that.
Thanks, Mary. On this next slide, to Mary's comment, currently available devices do have shortcomings and they need to evolve. False detections can be a problem in devices that aim to alarm for multiple seizure types. In addition to the points listed on this slide, there can be other barriers with device technology, such as compatibility with other data like health records, prescription info, and lab results, questions around data ownership and portability between platforms, and issues related to patient privacy, and also ambiguous expectations for who is monitoring the data device and when. So on this next slide, we talk about questions to ask when you're considering a device. It's not easy to stay current on all of the device options, especially when the marketplace and the pipeline is always changing. This is an area where we at Danny Did can be a resource. This is a good place for the reminder that Danny Did does not make or sell any products. Our role as an organization is not to recommend or endorse a specific device, but simply to let caregivers and patients know what their options are. Before picking a specific device system, it's important to go through a checklist of practical, common sense considerations. To help with that, Danny Did created the brochure on this slide, which is available on our website. So looking at the steps, the first being to figure out the best method for detecting your seizure types. So when considering an alert system, an obvious first step is to look at whether the device can detect the seizure types that you want to monitor. Different seizure types can be detected by different methods. We encourage patients and caregivers to talk with their doctors about if and how their seizure type can be detected. Number two is determining the goals, your goals for the device. So defining your motive for monitoring seizures helps to ensure the selected device meets that goal. So a couple of examples. One goal could be to notify someone when a seizure occurs. So if that is the goal, a major consideration is how the device sends alerts. So for example, is it through an audible alarm, a text message, an email, or a phone call to emergency contacts? Another goal might be to track how often seizures take place. So in that case, some considerations for that goal would include, is your child willing to be monitored? How does the device store data, and is that data secure? And how easily is the data shared with medical professionals? So looking at the third consideration, no device will be effective if it is not used correctly. So consider, will it be physically comfortable to wear? Is your child emotionally comfortable to use it? Are there weight restrictions, age restrictions? Where can the device be used? Inside the home, outside the home? Is it water resistant? Is it battery powered? All these kind of common sense considerations that are very important. The fourth factor we encourage is to understand what is required to use the device. So for example, are other technologies like internet access, cameras, or smart devices needed to support the monitoring system? Does the company that makes the system provide tutorials? We always encourage families to test whether the manufacturer provides strong customer support before you commit to using their product. And lastly, and perhaps the most commonly asked consideration, is the cost of the device. So some monitoring devices can have multiple costs, and questions to consider would include what is the base cost to purchase the system? Is there a monthly or annual fee in addition to that? Are there setup or maintenance costs or any other technology to support the system? And then is the device covered by insurance or a medical expense account? So next, Mary is going to briefly discuss a range of systems that are accessible now. The seizure detection field is booming, and the options have increased substantially in the last 10 years. There's much more in development than we will mention here. This short list that she will cover does not include mobile apps or technologies that are implanted, such as VNS or RNS.
Okay, let's start with the EMFIT. The EMFIT is made by a company called Epi USA in Texas, and EMFIT makes two products that may be of interest to people with epilepsy. The first is called the Movement Monitor, and it's a contactless detection device that monitors for movement activity during sleep. It's a thin product that sits between the mattress and the box spring, monitoring for the onset of repetitive movement. EMFIT also makes a second product called the EMFIT QS. It is also placed below the mattress and tracks multiple variables during sleep, including heart rate variability. The QS does not have the capacity to alarm, but you can review the data each morning. And the next slide, we'll just go over the Smartwatch Inspire app by Smart Monitor in California. It is designed to be used on a Samsung or Apple Watch to detect repetitive or shaking movements. When the Inspire detects seizure-like motion, it sends a signal to the app running on the user's paired smartphone to then send a text to the phone, or a text or a phone call alert to whomever the Smartwatch Inspire user designates as their emergency contact, such as multiple family members or other care providers. The next product is called the Embrace 2, which is a wristband system. It's made by Empatica, and it is designed to detect and alert for tonic-clonic or convulsive seizures after 20 seconds, and to monitor physical activity and rest. Embrace 2 transmits data to a paired smartphone via Bluetooth connection and has the ability to alert others via text message and phone call when certain seizures types occur. This system is FDA approved to indicate for movement for patients 6 and older, and it does require a prescription if you live in the United States. The next slide is the SAMI. The system focuses on nocturnal activity, and the SAMI stands for Sleep Activity Monitor. During sleep, audio, video information from a remote infrared video camera is placed near the bed and is sent, the information is sent to an app running on an iOS device, such as an iPhone or an iPad Touch. The SAMI app records and analyzes the video for unusual activity. When that unusual activity is detected, an alarm is sounded on the Apple device, which is usually placed in the parent's bedroom, followed by live sound and video from the SAMI network camera. If the alarm is triggered, the system records the event as well, and the recording can then be shared with your doctor. Another device is called MeQ, a product that was not specifically designed for epilepsy in mind. However, the system that uses radar technology can track many indicators, such as motion and sound in real time. You can set alerts for some of the features, and a key component is that it does send an alert if breathing ceases for 20 seconds. MeQ is marketed as a baby monitor, but it does not have age or size restrictions, so adults can use it. Added features specific to seizures are currently being studied at the Boston Children's Hospital. And the last one I'll discuss is the pulse oximeters. While these devices are not explicitly designed or manufactured to detect seizures, with their ability to measure heart rate and blood oxygen levels, pulse oximeters do have applicable monitoring and alarming sounding functions that can be useful to someone who experiences seizures. You will need to work with your doctor to obtain a pulse ox. And now I'll turn it back over to Tom for a preview on next generation of epilepsy technologies.
So it's definitely fair to say that non-invasive and wearable devices for epilepsy are still in the early stages, but in general, they are becoming more sophisticated and more reliable. Detection for generalized tonic-clonic seizures to alert caregivers and enable timely intervention is currently pretty strong. Detection for other types of seizures is the next chapter, and as many of you may know, there is a big need for it. You also know that seizure unpredictability is one of the greatest challenges of epilepsy. This slide shares what we see as the future for this field, including the Holy Grail, a non-invasive system that forecasts a seizure and delivers an intervention to suppress it. On the next slide, I want to talk a little bit about our grant program at Danny Did and how that works. We want to make sure that families who are made aware about seizure detection devices also have access to get them into place in their homes. So the way our process works is for someone to download the application on our website, which is dannydid.org, fill that out, and return it to us through email. After that is in place, we set up a phone call with each applicant and make sure that questions are answered and that the device appears to be a fit for the needs of the family. If the grant is awarded to the family, we fund the award directly to the caregivers, and then the caregivers place the order for the system themselves, typically through the product website. So again, our goal is to make the systems accessible, and many of these are cost prohibitive for some families who need them. We are here to help through the process, and we try to keep it as streamlined and as manageable as possible. So our website, dannydid.org, is the best place to start if you're looking to find out more about this program. So on our final slide, we just want to end by saying that we appreciate the chance to interact with you. Empowering the community with information is a huge part of our mission. We want to note that this educational content was made possible with support from our partners at VNS Therapy by LivaNova. We hope to keep in touch. We hope that you will reach out to us if you have questions or if there are ways that we can help.
Okay, I guess that is the end of our second presentation, and we're now going to move along to our third and last presentation. Before we get into question and answer, our next speaker is Crystal de la Grammaticus, and please correct me, Crystal, if I pronounced your name wrong. As she is from the Malan Syndrome Foundation. She's the director of research and the co-founder. She's also a full-time caregiver for her son, who was diagnosed in February of 2018 with Malan syndrome. I'm going to turn it over to Crystal.
And I am just trying to get to my slides. Oh, 1 second. Let me stop sharing. Oh, goodness. Really quick. Let's see here. So going back, you would think I would have this Zoom thing all figured out, but still having difficulties. But please bear with me. Okay, so I'm hoping you can see my slides now.
Yes.
I'm Crystal Delagrammaticus, and I'm delighted for the opportunity to speak to you all today, along with these distinguished panelists. I just want to thank Dr. Chung and the Danny Did Foundation for their incredible work they're doing to support families like mine. I'm here not only representing the Malan Syndrome Foundation, but I'm also here as a mom to a child with a rare genetic disorder. I think one of the most important things to do as an advocate is to share your story. So I'm going to start by sharing my family's journey to a diagnosis for my son. My son, Yanni, as you'll see on the slides, was born 14 years ago in November of 2009. And at the time, I was an academic researcher working in the Department of Neurology and Neuroscience. It's now known as the Brain Mind Institute at Weill Cornell Medical Center in New York City. Yanni was born a healthy baby boy, a little on the large size. We were praised for his good growth during our early newborn checks. His head was large too, but it turns out his dad has a large head. So there was never really any real concern there. They told us that big heads grew in our family or ran in the family. In his first year, Yanni was diagnosed with hypotonia and developmental delay. We had some chromosomal testing done and everything came back normal. 2 years later, after my son started showing more and more delays, I made the tough decision to leave work and become a full-time caregiver and coordinator for his care. The picture on the left you'll see is a picture of my son Yanni at 10 months old. He was just starting to sit up on his own. You can note his low tone, he's kind of slouching down. And at this point, he was in the 99th percentile for height and head circumference. You can see he has some distinct facial features, such as a broad forehead, low set ears. And if you look closely, he also has a lazy eye, and he started wearing glasses shortly after this photo was taken. As a first-time mom, I didn't pick up on any of this. I thought he was beautiful in every way. We continued on for the next several years with slow developmental progress. Yanni's growth stayed stable in the 90th percentile. We were not looking for a genetic cause for his delays, and no medical professional had put that on our radar. And we were seeing some of the top doctors at Weill Cornell and Columbia at the time. It wasn't until he started having seizures at 7 years old that we started to question what was going on with his development. Yanni was being seen at Columbia University. He was seeing a neurologist shortly after he had his second seizure. And then we were really lucky to be put into a research study offering trio whole exome sequencing. So that's when they offer genetics, exome sequencing to the child, but also the parents. And they were looking to identify rare genetic epilepsies. 10 months later, we heard back from the genetic counselor, and she told us that Yanni had a small error in a gene called NF1X, or nuclear factor 1X. And it was linked to a disorder called Malan syndrome. So using my academic training, I immediately jumped in and searched anything and everything I could find on Malan syndrome in the literature. And this is what I learned. I learned that it's an overgrowth and intellectual disability, and it was only described in 2010. So if you remember, my son was born in 2009. So when he was born, they didn't even know about this genetic condition. Some of the hallmark features are macrocephaly, and so that's the large head, overgrowth of the musculoskeletal system, hypotonia, intellectual disability, ranging from moderate to severe, and severe anxiety and aggression. So all of these I could check off, check, 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 check. Everything fit. Here on the right is a sketch of a typical body profile for someone with Malan syndrome. And it's very similar to Marfan. So it's described as having a Marfanoid presentation. And what that means is that individuals tend to have very long arms and legs. They're very thin, tall stature, long face, and some other defining characteristics. So later that same year that my son was diagnosed, I met 3 other moms through a small Facebook group. That was all I could find. And we were equally determined and passionate mothers. And we recognized very early on that we needed more information. We needed an organized foundation to provide families with information, since there's so little out there. And so we started the foundation. We are the only organization supporting Malan families worldwide, and we currently support close to 300 families in 32 countries. We have a scientific and medical advisory board with members both here in the United States and Johns Hopkins. Here in the United States at Johns Hopkins, and internationally in Australia, the Netherlands, and Italy. They're a very active group. They help us to develop informational resources. They attend and present at our conferences, and they guide us in our research efforts. Our board, we have 2. We have an executive board and we have a parent advisory board, and we're all volunteer and patient-led. So these are all parents of children with Malan syndrome. And in 2022, we had our first family and scientific conference. It was held in Chapel Hill, North Carolina. It was a great event, but more than anything, families just want to be connected. And this brought families together from all around the world. There's so many similarities that our children have. It was a great event, and we're getting ready to have another one this summer in Orlando, Florida. The 3 pillars of our organization are support, outreach, and research. And I want to focus on support, as it's very important to supporting the family. So how do we best support our community? What is most important to them? What are their unmet needs? And we learn more about that through putting out surveys, holding parent socials, and listening to what is being discussed, and paying attention to our support pages. What are the parents talking about? What matters to them? And one of the common topics that we noticed that was coming up over and over again was seizures. So in the literature, there's very little information on seizures and Malan syndrome. And we recently did a study with clinical researchers here. I'm in North Carolina, here at Duke and University of North Carolina. And this was on a large cohort of individuals with Malan syndrome. I think we received surveys from 50 individuals. And what we found from that cross-sectional study was that seizures are common in Malan syndrome. We see them in close to 50% of our population. And they tend to be late onset, so they're happening later in childhood and even into adulthood. And in fact, we had a family reach out to us last year. Their son was 49 years old, and he was showing signs of declining health. They were not diagnosed at that time, and it turned out that their 49-year-old son was starting to have seizures. And during the workup that was ordered by the doctor, genetic testing, whole exome sequencing was done on this individual, this man, and he learned that he had Malan syndrome. So he is one of the oldest in our community. So what do we need to do? We need to publish. We need to get these studies published. We need to do more studies. We need to know what types of seizures are happening with Malan syndrome and what treatments are most effective. This will better inform our doctors and support families in getting better care. So how do we inform our community and give them valuable tools and resources related to seizures? Well, we do this through outreach and forming partnerships with other organizations. One of those organizations is the Epilepsy Foundation. They have great training on how to recognize different seizures and seizure first aid. We'll also work with school personnel, teachers, nurses to provide trainings. The Epilepsy Foundation will also be attending our family conference this summer to share information with their families and let them know about the resources that they have. We also share information on seizure action plans and encourage our families to have one in place for a child that is having seizures and also for a child that is not having seizures but has Malan syndrome. It's best to be prepared in these situations because when seizures happen, things happen quickly. They can be scary, as I can relate to, and you can often not think straight. So it's best to have a plan in place. And this action plan can be shared with anyone that cares for your child, including babysitters and teachers. And we often refer families to the Danny Did Foundation to learn about the seizure detection devices that are available. And they have great webinars on all the detection devices. So it's a tremendous resource. At the foundation level, we are a member of the Rare Epilepsy Network, or REN, trying to work with other rare advocacy groups on pertinent issues, legislation, and increasing funding for the epilepsies. And we've also formed collaborations with other overgrowth patient organizations to identify symptoms that are observed across syndromes and how we can best work together to support research to better understand these symptoms. We have since launched the Overgrowth Syndromes Alliance, the OSA, and that includes 11 different overgrowth organizations, some of them being the Tatton-Brown-Raman syndrome community, the Clove syndrome community, Soto syndrome, Smith-Kingsmore syndrome, and Beck-Farner syndrome foundations. One of the first things that we did as an alliance was to send out a patient priority survey. And this was disseminated through all of these different foundations to the various different patient populations. And we had close to 400 respondents and learned that seizures are among the top priorities across overgrowth syndromes. We have since worked together to write a paper to provide patient perspective for epilepsy and overgrowth intellectual disability syndromes. And we are pleased that our paper has been peer-reviewed and accepted for publication, and hopefully it will be out this month or next month. So these are some of the ways in which we are trying to support our families, both with Malan syndrome and in the broader overgrowth syndrome space. But we recognize that we have so much more work to do. I'd like to thank you for your attention, and I'll pass it back to the organizers.
Thank you, Crystal, for your presentation, and thank you, all of our speakers, Dr. Wendy Chung, Tom Stanton. We'll begin our Q&A, and we will stop recording now, and then we're going to open